well. So continue with our rest of endometriosis lecture. As I have told you about that for NICE guideline, you have not to read all the guideline, but the two table that is very simple. Just go through it. In ASHRAE, they have given detail regarding the endometriosis. So we have just go through with these tables. So suspected endometriosis included in young women aged 17 or under 17 and under with one of the following features, that is chronic pelvic pain, period related pain, dysmenorrhea affecting quality of activities and quality of life, deep pain during or after intercourse, period related or cyclical gastrointestinal symptoms, in particularly painful bowel movements, period related or cyclical urinary symptoms, in particularly blood in the urine or passing urine, or infertility in association with one of the following above. So assess the individual information and support the needs. So it is a very important because it will affect the patient life on daily activities. So you have to take the detailed history and provide a physical, psychological and emotional support to these patients. So first of all, you will discuss keeping a pain and symptom diary. Symptom diary means that you have to tell the patient that she make take a page and detail of that at what time she feel pain, whether it's related to only menses or throughout she feel pain. Offer abdomen and pelvic examination to identify abdominal massing and pelvic sign. Consider an ultrasound scan. Okay, so we have to do with abdominal pelvic examination and to identify the masses, and then we will consider ultrasound scan. So better option is transvaginal scan, but young patient that are not sexually active, then we will do transabdominal ultrasound. So be aware that endometriosis can be a long-term condition and can have a significant physical, sexual and psychological and social impact. So first of all, offer initial management with a short trial, for example 3 months of paracetamol or NSAID, or alone or in combination with hormonal treatment. If consider referral to gynae and pediatric and adolescent gynecology or specialist endometriosis if the trial of paracetamol or NSAID does not provide adequate pain relief. So initial hormonal treatment from endometriosis is not effective, not tolerated and is contraindicated. So first of all, I have told you about previously, when the patient came with such symptoms, you have to start with medical management if the patient have no fertility is not her priority. Okay, in young age or those have no fertility is a priority, so you have to start a 3-month trial of analgesia alone or with hormonal treatment. If the patient does not respond to these, then we have to consider refer to gynae services, refer to women at specialist endometriotic services if the patient have a deep endometriosis that involve bowel, bladder and ureter. So we have to need a specialist service in that cases. But consider referring young women age 17 or under to a pediatric and adolescent gynecology service or specialist endometriosis. So they have divided because in UK they have in UK individual services they have multiple specialities in specific that in endometriosis they have another specialty for endometriosis. So in UK they have in specific, for example as in Pakistan, infertility specialist there. So in UK there is endometriosis specialist. So we have to refer these patients to concern endometriosis specialist. But as in Pakistan we don't have such type of specialty services so a simple gynecologist can treat such type of patient. So then if the patient is if the fertility is the priority, then a management of endometriosis related subfertility should have multidisciplinary team involvement. As if the fertility is a concern, so we have to not to start with the NSAIDs or hormonal treatment because at fertility is her concern. Do not use pelvic MRI CA125 to diagnose endometriosis. MRI is only indicated if you suspect deep endometriosis that involve bowel, bladder, and rectum. So before proceeding toward the diagnostic laparoscopy, so we have to do MRI, because if we will do direct diagnostic laparoscopy, there may be chance that we have to damage the bowel bladder because they are very extensive adhesions. So consider transvaginal ultrasound to investigate suspected endometriosis if abdominal pelvic examination are normal for endometrioma and deep endometriosis involving the bowel, bladder, or ureter. Consider transabdominal ultrasound if TVS is not appropriate. If, for example, if couldn't find any findings on the TVS, then you can do transabdominal ultrasound. But in young girls that are not sexually active, you will consider a transabdominal ultrasound. Do not exclude the possibility of endometriosis if abdominal or pelvic examination or ultrasound or MRI are normal. So consider referral for assessment and investigation if clinical suspicion remain or symptom persist. If you didn't find any findings on the pelvic or abdominal ultrasound, then you have to start the treatment. If the patient is still not the symptoms are not relieved with the treatment, then we'll proceed toward the advanced investigation. So the advanced are the way consider laparoscopy to diagnose endometriosis if the ultrasound was normal. So the management options are what laparoscopy involves, that includes surgical treatment with prior patient consent, how laparoscopic surgery could affect endometriosis symptom, the possible benefits and risk of. So you have to explain all these things with the patient. So that we are doing laparoscopy. So what are the benefits of laparoscopy? What are the aim? Okay, so the possible benefit of risk of laparoscopy surgery we have to discuss with the patient. The possible need for further surgery include possible need for further planned surgery or deep endometriosis involving the bowel, bladder, and ureter. So during diagnostic laparoscopy, gynecologists with trained skill in laparoscopy for endometriosis should perform a systemic inspection of the pelvis. When you are planned for diagnostic laparoscopy, when we insert the laparoscope, you will first check all the abdomen thoroughly at 360-degree view. Then you will check the uterus, ovaries, utrovesical pouch of Douglas, peritoneum for any endometriotic spots. If full systematic laparoscopy is performed and is normal, explain to the woman that they does not have endometriosis and offer alternative management. Okay, because on laparoscopy you didn't find any endometriotic spot, then you have to counsel that laparoscopy is normal. So you have to identify other causes, because in chronic pelvic pain, one of the causes is endometriosis, but there are so many causes of chronic pelvic pain, so you have to rule out that. In chronic pelvic pain causes are bladder pain syndrome, musculoskeletal pain, or any ovarian pelvic pain congestion. So different causes I have discussed in chronic pelvic pain. So if fertility is priority, infertility, so we have offer excision or ablation plus adhesiolysis to women with endometriosis not involving the bowel, bladder, or ureter. Offer laparoscopic ovarian cystectomy to women with endometrioma. So those having endometrioma of more than centimeter, we offer ovarian cystectomy, but less than 3 centimeter, we will not offer ovarian cystectomy. Then discuss the benefits of laparoscopy surgery for deep endometriosis. Do not offer hormonal treatment to women with endometriosis who want to conceive, and consider outpatient follow-up for deep endometriosis involving the bowel, bladder, or ureter, or one or more endometrioma larger than 3 centimeter. Okay. Then if fertility is not currently priority, so we have to start with the treatment. Diagnostic laparoscopy, consider laparoscopic treatment if peritoneal endometriosis not involving the bowel, bladder, or ureter, and uncomplicated ovarian endometrioma. So during diagnostic laparoscopy, so we have to do laparoscopic treatment, and there is peritoneal endometriosis and uncomplicated ovarian endometrioma, so we have to remove it. Consider excision rather than ablation to treat endometriomas. And for deep endometriosis involving the bowel, bladder, and ureter, consider pelvic MRI before operative laparoscopy, 3 months course of GnRH before the surgery. Consider hormonal treatment after laparoscopic excision or ablation. If hysterectomy is indicated, so excise all the visible endometriotic lesion at the time of hysterectomy. Discuss with the woman what is hysterectomy and risk benefit and related treatment. So it is a very beautifully explained that if the fertility is priority, what we have to do, and if the fertility is not currently a priority, what we have to do. So you have to memorize it, and it's a very good table. So for that, you have to listen the lecture, make a points of what for MCQ what I have told you, so mark that points and just do this table. It's enough for your exam. So diagnosis of endometriosis, as already they have beautifully explained the sign and symptoms, then explore a diagnosis, consider vaginal examination, then imaging, ultrasound or MRI. Okay, then differential diagnosis followed appropriately. If sign of endometriosis, further diagnostic tests depend upon the and empirical medical treatment you have to start with the patient. If the patient need fertility, so you will do, you have not to start the medical treatment, you will do diagnostic laparoscopy directly, excision and ablation, and give her ovulation induction. But if the patient have no fertility issue, then we have to follow this table, that empirical treatment. If the empirical treatment is unsuccessful, then we have to plan the laparoscopy. But those have fertility concerns, so we have to direct to initially do a laparoscopy if we are suspecting endometriosis. So consider excision or ablation. Undetermined ovarian masses, investigate and follow up according to the local protocols. So the proceed to the treatment of endometriosis. If you have to state the disease, biopsy shows endometriosis, you have removed all the endometriotic spots. Then for prevention of recurrence, we will start her on continuous combined hormonal treatment or levonorgestrel for 18 to 24 months. For different options are available, NSAIDs and analgesias, hormone treatment offer an option, and surgery. Surgery आप कब करेंगे? When the medical treatment failed. So different options they have discussed regarding what are the combined oral hormonal different preparation. And GnRH agonists, they have told that it is a second line treatment. If first line treatment is COCPs and progesterone. Consider combine hormonal add-back therapy to prevent bone loss and hypoestrogenic symptom. As I have told you that you have to take more than 6 months, so it will the side effects are menopausal symptom, osteoporosis, so we will give add-back therapy of hormone replacement therapy. So aromatase inhibitor, GnRH, they are second line. Non-pharmacological treatment for pain, they have they have discussed that they have no benefits, no recommendation can be made for specific intervention. So at the end, endometriosis buzzwords, what we have to memorize, this is very important. So at the last lectures, if you have listened the lecture, then it's a gift slide for you people, that for memorization, that what are the important points you have to memorize. So diagnosis are symptoms. What are the symptoms? Dysmenorrhea, deep dysmenorrhea, chronic pelvic pain. So in history, the patient also had in history regarding the dysmenorrhea. So the pain start before the menstrual cycle, and the intensity increases with the cycle. So this is endometriosis. But when the patient said that her pain is her pain start before the menses, but it improve with the menses. So in that case, this is chronic PID. So you have to differentiate the pain of differentiate the pain of endometriosis or chronic PID. Okay. So the secondary dysmenorrhea, deep dyspareunia, chronic pelvic pain, infertility, bowel or bladder without abnormal bleeding or pain, dyschezia. Empirical treatment counseling, the other are analgesia, progesterone or COCPs, GnRH may be taken short term. First line investigation, I have told is TVS. If inconclusive deep endometriosis, then we have to do MRI. Gold standard investigation is laparoscopy. First hormone you have to do is first line hormonal treatment is combined oral contraceptive, COCPs, and the first analgesia is NSAID. Okay, so if the patient want fertility, so and patient presented with pain, so you have to avoid NSAID because it is antiprostaglandin and it will affect, it will cause luteinization. So the surgery are excision rather than ablation. Okay, so choose excision, not ablation. Okay, so we will consider excision rather than ablation. And HRT, if the patient need HRT, surgical menopause or natural menopause, so it would be combined HRT. So these are MCQ points and also for talks related. So very simple. Okay, so the NICE guidelines and ASHRAE, they have combined that TVS first line not diagnosed it, transabdominal TVS, if not possible, then we will do transabdominal. Okay, so they are very beautifully explained. This is a flashcard for you people. MRI, deep endometriosis, but not a primary test, and laparoscopy, it nothing helpful, but in infertility, it is helpful. So for gold standard and diagnosis is laparoscopy. So if a full systemic laparoscopy is performed and is normal, explain to the woman that she does not have endometriosis and offer alternative management. CA125 can be raised in endometriosis, but not sensitive and not recommended. So endometriosis, NICE talk 2024 and ASHRAE 2022. So combined, they have they have explained the same thing, that in medical management, non-hormonal, hormonal, surgical if medical treatment fail or not suitable, conservative surgery, radical surgery plus HRT combined if a patient is does not want fertility. First line continues OCP. After OCPs, we will give progesterone. Second line GnRH with add-back therapy. Third line aromatase inhibitors. Aromatase inhibitors, as we have read in ASHRAE guidelines, that it is a third line if the all medical treatment fail and surgery and medical and surgical both medical and surgical management fail, then we will prescribe aromatase inhibitor. Danazole not recommended in routine because it have certain side effects like virilization symptoms, so we will not recommend danazole now. Surgery, if medical treatment fail or not suitable, conservative surgery, endometrioma removal, excision or ablation of and radical surgery, total hysterectomy with or without BSO. For those with the infertility management stage 1 and 2 conservative surgery, ASHRAE recommend that laparoscopy could be offered for early stage endometriosis and improve the rate of ongoing pregnancy. I've already told you that it will improve the ongoing in stage 1 and stage 2. If no pregnancy till 2 years, we will offer her IVF. Expectant care, and if no pregnancy till 2 years, then we will do IVF or other ART, artificial reproductive techniques. Stage 3 and 3-4 IVF endometrioma surgery only if more than 4 centimeter before ART. But as we have told that we can consider in ASHRAE, I have explained in detail that in first they say that it is usually does not have any impact on improvement in fertility in regarding the as in stage 1 and 2 it improves the rate of ongoing pregnancy, but in stage 3 and 4 we will to remove the endometrioma only if we will consider to remove the endometrioma if there is associated pain or if we have for visualization of the follicles. So in that case we have to remove endometrioma. Otherwise for to improve the rate of ongoing pregnancy, it have a no role that we have to remove endometrioma. Surgical techniques for infertility stage 1 to do excision ablation of ovarian endometrioma, cystectomy with cyst wall removal, aim to enhance spontaneous conception, use EFI score for non-IVF pregnancy to decide about the surgery. Stage 3 and stage 4 excision and ablation of endometrioma more than 4 cm, cystectomy with cyst wall remove, aim to chance of pregnancy. Bigger endometrioma more than 5 cm, do stage 3 removal. Okay? So stage 3 large cyst more than 5, previous cystectomy to preserve ovarian function in infertility. If previous is cystectomies and if there is a large cyst more than 5 centimeter and previously cystectomies have been done, so in that case you will do laparoscopic cyst drainage followed by GnRH down regulation and with repeat laparoscopy to excite the cyst capsule. So what is the endometriosis fertility index score? as we have told that we have to check that what is her EFI. So it was developed to predict pregnancy rate in women with surgically assisted endometriosis attempting non-IVF for shared decision making about whether to perform surgery for endometriosis associated infertility. So before that, if the patient, if fertility is the issue, so first of all we will check the EFI. In EFI score, what we have to check that pre-op pregnancy accurate assessment done by viewing woman, what are the symptoms, what is her age, history of previous surgery, the presence of other infertility factors, and ovarian reserve. If the ovarian reserve are low and other fertility factors like male factor infertility, so we have to direct proceed towards the artificial reproductive techniques. We will not waste her time on the ovulation induction IUI. So that's why AFI score is very important. So before proceeding toward the surgery for endometriosis, if you are suspecting stage 1 and stage 2, but before you have to assess that what are the patient's symptoms, what is her age, and what about whether any previous surgery previously done, and what are other fertility factors, there is any other comorbidity along with endometriosis, and there is male infertility, or what about her ovarian reserve? If her age is more than 35 or 39, because then her ovarian reserve will be reduced. So in that cases, you will must assess the EFI score. Then you will decide that whether we have to give a chance of ovulation surgery and we will do ovulation induction, or we will proceed toward the artificial reproductive technique. So EFI is equal to total historical factors plus total surgical factors. Okay, so this is the endometriosis, and regarding the endometriosis, hope you find the lecture good, and any queries, then you have to DM on the WhatsApp group. Okay, thank you so much. Allah Hafiz.